Welcome to part 3 of the 4-part video series entitled Medical Mycology from the Perspective of the Dermatologist. I'm Maria Caterina Latherin. At the end of parts 3 and 4, the dermatology resident will be able to define what are the endemic and opportunistic mycoses, present the most common causes of endemic and opportunistic systemic mycosis, correlate the morphology of fungi to the clinical presentation of said mycosis, apply the appropriate method of diagnosing fungal diseases, select the most appropriate management for such infections, and formulate measures for the prevention and control of fungal diseases. The following are the main references. We now proceed to endemic systemic mycosis, which are a group of diseases caused by fungi from soil. These fungi are dimorphic, and transmission is mainly through inhalation of their conidia. Most cases are asymptomatic or mild. Upon inhalation of the conidia, the alveolar macrophages engulf and digest the conidia, and they are capable of inactivating the conidia. This usually leads to granulomatous inflammation with activation of your humoral immunity and cell-mediated immunity. These processes in turn activate macrophages to enhance fungicidal capacity of the host immune system, leading to resolution. Residual granulomata may retain dormant organisms, and these have the potential for reactivation when one becomes immunocompromised. These individuals then would become symptomatic with the additional possibility of spreading infection to different organs. Some of these fungi display alpha-glucan in their cell walls, which may mask pathogen-associated molecular patterns that trigger host immune response. We will be tackling the 4 primary causes of endemic systemic mycosis. We begin with coccidioidomycosis, which is mainly caused by Coccidioides immitis. When you culture it, you will see the colonies to be white to tan-colored and cottony in consistency. From that colony, if you get specimen for microscopy, you will see arthroconidia that fragment easily to release spores. The arthrospores are lightweight and very infectious. Specimens can be pus, sputum, or tissue. On histology of the tissue specimen, you will see a spherule with double refractile wall. You can get infection through inhalation, and you only need less than 10 arthroconidia to get infected. Most of the time, the infection is self-limited. Systemic spread is rare, but it can be fatal. More commonly, you get asymptomatic respiratory infection, where you develop antibodies, which results in positive skin test after 2 to 3 weeks of infection. Mild flu-like symptoms may appear 1 to 2 weeks after infection. You may also present with skin lesions like erythema nodosum or erythema multiforme. More than half of cases have changes seen in chest X-ray. Approximately 1% can become disseminated and is fatal. They have noted racial predilection in Filipinos, African Americans, Native Americans, Hispanics, and Asians. And they also note that it is more commonly seen in the pregnant. Coccidioides immitis has estrogen-binding proteins, and elevated levels of estradiol and progesterone stimulate its growth. Specimens include sputum, exudate from skin lesions, spinal fluid, blood, urine, and tissue biopsy. Fresh specimens should be used for detecting spherules under the microscope. KOH or chalcofluor white stain will facilitate in finding the spherules and endospores. Fungal culture can be done using IMA or BHI blood agar slants at 37 degrees centigrade. Confirmation can also be done using animal inoculation or specific DNA probe. There's a skin test making use of your coccidioidin and spherulin to check for presence of antibodies. There are serologic studies specifically to test for presence of precipitating antibodies, your IgG and IgM, which can be present 2 to 4 weeks after infection. Complement fixation antibody tests can be positive up to 6 to 8 weeks after infection in low titers. If you do find high titers, especially in disseminated coccidioidomycosis, it usually signifies poor prognosis. Primary infection with C. imitis is self-limited and usually requires only supportive treatment. Disseminated infection will require treatment with amphotericin B for several months. Azoles are only moderately effective in treating chronic pulmonary infection, but they are easier to administer and have less side effects. For histoplasmosis, this is caused mainly by Histoplasma capsulatum. In nature, Histoplasma capsulatum grows as a mold associated with soil and avian habitats enriched by nitrogen in guano and bird feces. At temperature less than 37 degrees centigrade, they grow into brown mold colonies, but the appearance may vary. In tissue or in vitro enriched medium at 37 degrees centigrade, the hyphae and conidia convert to small, oval yeast cells 2 to 4 microns in diameter, and in tissue the yeasts are seen within macrophages. Histoplasmin is filtrate antigen used for skin testing, with more than 95% of asymptomatic individuals showing a positive delayed type skin reaction. Serologic testing for both yeast antigen and mycelia antigen can be done. Most individuals will be asymptomatic. After inhalation and action by the alveolar macrophages, the yeasts may disseminate to the reticuloendothelial system. Inhalation of conidia, which develop into yeast, are engulfed by alveolar macrophages, within which they are able to replicate. In more than 95%, the resulting cell-mediated immune response leads to secretion of cytokines that activate macrophages to inhibit the intracellular growth of the yeast. Individuals may present with acute pulmonary histoplasmosis, chronic pulmonary histoplasmosis, or severe disseminated histoplasmosis. Specimens for culture include skin scrapings, sputum, bronchial washings. Microscopy will show small ovoid cells within macrophages in tissue sections, best viewed with special stains. Histoplasmin skin test becomes positive soon after infection and remains positive for years. Repeated skin testing stimulates production of antibodies, and this can interfere with diagnostic interpretation. Specimens are cultured in rich media such as your glucose-sustained blood agar at 37 degrees centigrade or on SDA or IMA at 25 to 30 degrees centigrade or room temperature. These are incubated for a minimum of 4 weeks. Growth is confirmed using in vitro conversion to yeast form, detection of species-specific antigen, or PCR. Complement fixation tests for antibodies to histoplasmin or yeast cells become positive within 2 to 5 weeks after infection. They also rise during progressive disease and then decline to very low levels when the disease is inactive. For the immunodiffusion test, antibodies against the H antigen signifies active infection, while those for M antigen may be due to repeated skin testing or past exposure. Radioassay or enzyme immunoassay is one of the most sensitive tests for circulating antigens. These drop after successful treatment and recur during relapse. While cross-reactions may occur, this antigen test is more sensitive than conventional antibody tests in AIDS patients with histoplasmosis. Acute pulmonary histoplasmosis usually is treated by rest and supportive therapy. Itraconazole is given for mild to moderate infection. In disseminated disease, amphotericin B is usually curative, although patients may need prolonged treatment and monitoring for relapses. Blastomycosis is caused by Blastomyces dermatitis. On SDA at room temperature, it grows as a mold, which is described as white or brownish colony with branching hyphae, bearing spherical ovoid or piriform conidia on slender terminal or lateral conidiophores. At 37 degrees centigrade or in the host, it converts to a large, thick-walled, multinucleated spherical yeast that usually produce single buds. The bud and the parent yeast are attached to each other with a broad base. The bud enlarges to the same size as the parent yeast before it detaches. The yeast colonies are wrinkled, waxy, and soft. Blastomycin is the antigen used for the skin test. Patients are often negative or lose their reactivity, and false positive cross-reactions occur in people exposed to other fungi. The frequency of primary pulmonary stage is unknown because there is no adequate skin or serologic test with which to assess subclinical or resolved primary infections. So most of them are asymptomatic, and if they do present with symptoms, it is usually nonspecific. When dissemination occurs, skin lesions on exposed surfaces are most common, seen as raised ulcerated verrucous granulomas with advancing border and central scarring, which can evolve to ulcers. Blastomycosis can involve the bones, genitourinary tract, and CNS. Using skin scrapings, sputum, and bronchial washings, you may visualize under direct microscopy the thick-walled yeast cells with buds attached on a broad base. Identification is confirmed by conversion to yeast form after cultivation in rich medium, or by extraction and detection of B. dermatitis specific antigen or specific DNA proof. Overall, serologic tests are not as useful for the diagnosis of blastomycosis compared to other endemic mycosis. In patients with localized lesions, a 6-month course of itraconazole is effective. Severe cases of blastomycosis are treated with amphotericin B. Paracoccidioidomycosis is caused by Paracoccidioides brasiliensis. Cultures of the mold grow very slowly and produce chlamydospores and conidia. The features are not distinctive. At 37 degrees centigrade on rich medium, it forms large multiple budding yeast cells. The yeasts are larger and have thinner walls than those of B. dermatitis. The buds are attached by narrow connection. Paracoccidioidomycosis starts with inapparent lung infection, which may be dormant for decades. When dissemination occurs, the yeast spreads from lungs to other organs, particularly the skin and mucocutaneous tissue, lymph nodes, spleen, liver, etc. Histology reveals central caseation with the yeast frequently observed inside giant cells. Confirmation again has to be conversion to yeast form by in vitro growth at 37 degrees centigrade. Serologic testing is most useful for diagnosis with antibody to paracoccidioidin measured by complement fixation or immunodiffusion. Healthy persons in endemic areas do not have antibodies to Paracoccidioides brasiliensis. Paracoccidioidin, if used for skin tests, may cross-react with coccidioidin and histoplasmin. Itraconazole appears to be the most effective against paracoccidioidomycosis, but ketoconazole and trimethoprim sulfamethoxazole are also efficacious. Severe disease can be treated with amphotericin B. Key points in part 3 of this lecture are: the endemic mycosis are characterized by distinct geographic areas of distribution and caused by dimorphic environmental modes. More than 90% begin by inhalation of conidia, and within the lungs, they are converted to distinctive yeast cells. In their endemic areas, rates of infection with Coccidioides, Histoplasma capsulatum, and Paracoccidioides brasiliensis are very high, but approximately 90% of infections occur in immunocompetent individuals who are asymptomatic or present with self-limited disease. Immunocompromised individuals are at significantly greater risk of developing disseminated disease. Incidence of disseminated disease is significantly higher in males, and serologic tests for serum antibodies have diagnostic and prognostic value. This is the end of part 3 of the 4-part video series on medical mycology. See you in part 4.